Now, moving towards the last session of the day, interesting motility cases and video contestant. So, for this session, we have received 25 video presentations, out of which only 5 are selected by the judges. Out of the 5 selected contestants, only 3 will be rewarded by the judges. And all the contestants, please hear out the instruction carefully. All the contestants will be given 4 minutes for presentations and 2 minutes for discussion. Exceeding the time limit may reduce your chances for selection. Kindly stick to the permitted time. I would like to call our first presenter, Dr. Preeti Gandhi. For this session, calling upon judges Dr. Piyush Ranjan, Dr. V.G. Mohan Prasad, Dr. Umesh Goyal, Dr. Matthew Philip, Dr. Shobna Bhatia. Our first video presenter, Dr. Preeti Gandhi, going to present on a topic, chronic colonic pseudo-obstruction challenges.
Good evening, one and all. I thank for giving me this opportunity and platform to present this case. So here is a 26-year-old married lady who presented to our hospital with acute worsening of abdominal distension, vomiting, and constipation. Her abdomen was diffusely distended. Her rectum was loaded with stools. So basic blood investigations, including the electrolytes and thyroid profile, was within normal limit. So provisionally, a diagnosis of colonic pseudo-obstruction was made that was confirmed with the CT abdomen findings. She also has a significant past history with recurrent GI symptoms reported from the age of 8 years. Initially, it was neglected. Later, she tried some homemade remedies and alternative medicines. When the symptoms started to worsen, she consulted a nearby physician where she was put on various laxatives. She also has a bad obstetric history where she has history of IUD at 9 months of gestation, and this happened 5 years ago. So prior to admission at our center, she was evaluated elsewhere. Colonoscopy showed a dilated colon, and anorectal manometry, the REIR, was present. She was put on multiple laxatives, however, symptoms did not subside. So when she presented to our center, we further went ahead and did other workup. So the blood lead levels was within normal limit. A neurologist with special interest in myopathy, the opinion was taken in view of bilateral thigh pain. However, on examination, there was no relevant findings and the CPK was within normal limit. So at this point, we went ahead and did a full thickness rectal biopsy, which will be elaborated in the subsequent slide. So on a later date, we even did a gastric emptying time, which showed a delay in the gastric emptying. So the management with multiple enemas was given, and initially a combination of various laxatives. So even prucalopride and pyridostigmine was put. So with that, there was some improvement. Gradually, we reduced the dosage of each medication, and eventually we stopped because a daily dose of enema was sufficient for her to clear bowel. So subsequently, her weight also gained and her appetite improved. Coming to the full thickness rectal biopsy, so as we can see that the myenteric plexus was intact with well ganglionated cells. So thus, a visceral neuropathy was ruled out at this point. But however, both the layers of the muscularis propria showed a marked atrophy. So it was supported by the IHC, where there was poor expression of the SMA. So keeping in background of a muscular atrophy, we went ahead and did genetic studies. So that showed a rare homozygous LIG3 gene defect, so which is autosomal recessive inheritance. She is born to non-consanguineously married couples. So both her parents were tested for this gene and they were carriers. She is married third degree consanguineously. Fortunately, the husband was tested and he's not a carrier for the variant of this LIG3 gene. So this is the LIG3 gene. So our patient had in the exon 20 a missense mutation. So thus the diagnosis is a mitochondrial DNA depletion syndrome 20. So which is a rare type, and it is actually an MNGI type with autosomal recessive inheritance. So as we can see, the clinical synopsis reported with this rare case, it is multi-system. Our patient had predominantly abdominal symptoms with a delay in the gastric emptying. And further, our patient did not report any significant neurological symptoms. So two published articles regarding this, that is Bonoro et al. And Ivanizzi et al. Have reported few cases where they had profound and progressive GI dysmotility, which required a colectomy or ileostomy at one stage. The cases that have reported have also reported about these severe neurological involvement in the form of refractory seizures as well as fatal myopathy. So coming to our patient, as of now, she is pregnant. She is in her second trimester. In the end of the first trimester, she had constipation and further again urinary retentions, which required intermittent catheterization. So now she requires twice daily enema. With that, there is good response. The risk of atonic PPH and non-progression of labor has been counseled the patient family as well as the treating obstetrician. So I would like to end by highlighting the case that it is a rare autosomal multisystem disorder, and our patient had only chronic colonic pseudo-obstruction without significant neurological involvement. So though it is rare, if suspected, can be detected. So the challenges that we are facing in this chronic treatment is a trial and modification of the available medicines, further ensuring a safe outcome of pregnancy. Thank you.
Dr. Predi, it's a very interesting case. This is M.I.C.E syndrome, and she had multiple systems are involved. And any family history of other relatives?
No, sir. No family history at all.
And the only symptom she presented to you was with the lower GI symptoms.
Yes, sir. Yes, sir.
And you have mentioned that she required some catheterization in the genitourinary
Yes,
also. Was it at the same time or on follow-up?
So during her pregnancy, this was the first time that happened. So that at the end of the first trimester and beginning of second trimester, she had this urinary retention. So we have done only a uroflowmetry that is showing a low flow rate. And after twice catheterization, now she's able to pass urine. So as of now, she's not requiring an catheterization.
What is the duration of follow-up for this patient? How long you are following this patient now?
2 years, sir. She's been following.
Any other questions?
What is the treatment that she's on at the moment?
She's only receiving enema, sir. So initially we tried various laxatives. So we had to cut down one by one because of other symptoms associated. So with just enema, she's able to pass stools like every day. But presently we're putting her twice daily enema during her pregnancy, sir.
Thank you.
Did you do a colonic transit time study? Sorry?
No, sir. For this patient, we haven't done, sir. No.
That could have been helpful to see
Helpful.
that.
Yes, sir. Yes. Thank you.
Thank you.
Thank you.
Thank you so much, ma'am. Calling upon the stage our second presenter, Dr. Shravan G.H., going to present on a topic, a rare case of vincristine-induced acute colonic pseudo-obstruction.
Good evening, everybody. I am Dr. Shravan from Tata Memorial Hospital, Mumbai. Today, I am presenting a rare case of vincristine-induced acute colonic pseudo-obstruction. We had a 17-year female who presented with fever and left-sided cervical lymphadenopathy of 20 days duration. And further workup, she was diagnosed to have T-cell lymphoblastic leukemia, and she was planned and started on modified Berlin Frankfurt Munster 90 regimen, which includes prednisolone, vincristine, daunorubicin, L-asparginase, intrathecal methotrexate, and 6-mercaptopurine. She was started on induction phase from 25th of October, and accordingly she received prednisolone and vincristine, daunorubicin, L-asparginase, and methotrexate on day 8 and day 15. On day 18, she presented to us with history of constipation, diffuse abdominal pain, and abdominal distension. Clinically, she was vitally stable with PS2, and there was mild abdominal tenderness with tympanic distension, and bowel sounds were sluggish, and abdominal girth was 82 centimeters. And blood investigations revealed pancytopenia, likely due to the chemotherapy. The rest of the investigations, including RFT, electrolytes, amylase, lipase, were normal. Her abdominal X-ray revealed mildly dilated large bowel loops. There were no air fluid levels. So she was initially managed conservatively with sodium phosphate enema, which resulted in passage of small amount of stools. However, there was no significantly improvement in the abdominal discomfort. She was also given a trial of prokinetic with IV metoclopramide, following which she developed extrapyramidal symptoms, which reversed immediately with injection promethazine. And the subsequent day, she developed a episode of fever, and there was progressively increase in the abdominal distension, and she developed tachycardia, and abdominal girth increased from 82 to 84 centimeters, and a trial of phosphate enema was retried. However, there was no significant improvement, and Ryle's tube and flatus tube was inserted, and other conservative measures were continued. Her X-ray abdomen revealed fecal-loaded cecum with dilated ascending transverse and descending colon. The sigmoid and the rectum appears to be collapsed, maybe due to the flatus tube. And the subsequent day, she underwent CCT abdomen, which showed uniformly dilated large intestine from the cecum to the descending colon. There was no transition point, or there was no thickening of the colon, and there was a fecal loaded dilated cecum of up to 10.2 centimeters. Transverse colon was dilated up to 8.24 centimeters, and there was fecalization of the intestinal loops. So we had an MDT discussion involving the medical gastro, surgical gastro, and treating hemato-oncological team. The main concerns were progressively increase in the abdominal distension and pain, and failed conservative therapy for more than 72 hours, and distended thin cecum and transverse colon with background pancytopenia. So the available therapeutic options were discussed. We advised neostigmine trial because it is a first line therapy advised by many societies, and it was used in similar cases with positive results, and it is non-invasive. However, there were concerns of the concerns regarding the side effect profile, and this patient already had rare side effects of the two drugs. So the other available options are colonoscopy and colonic decompression tube placement, which is minimally invasive and it is immediately available. Surgery being the last option because it is carried only when the other two options are failed and carries high morbidity and mortality. So subsequently she underwent colonoscopy, and there were few stercoral ulcers in the sigmoid colon, and colonic decompression tube was placed under fluoroscopic guidance, and she had progressively improvement of the symptoms, and she passed flatus and stools by day 7, and abdominal girth reduced from 86 to 80 centimeters, and there was X-ray abdomen revealed the progressive decrease in the distension of the gas. So vincristine toxicity. Vincristine is one of the commonly used chemotherapy in various regimens, and vincristine-induced neurotoxicity is very frequent, and the GI side effects occurs in approximately 50% of the cases. The most common being constipation and abdominal cramps, and ACPO occurs in less than 5% of the cases. So we had here we have 9 patients, of which 2 patients had gastroparesis, 3 patients have underwent conservative management, 1 patient responded to neostigmine. So to summarize, it's an vincristine-induced acute colonic pseudo-obstruction is a rare adverse event. Usual common risk factors for acute colonic pseudo-obstruction usually occurs in elderly age with comorbidities or post-operative. But our patient, apart from vincristine, she didn't have any other risk factors, and prokinetic optimal use of prokinetic has been precluded by its adverse effect. Thank you.
Thank you, Shavan. So, vincristine induces colonic pseudo-obstruction by neurotoxicity, you said.
Yes, and because of the
So, in this
neuropathy.
condition, is neostigmine going to help?
Sir, sir,
In this condition, if that is the underlying pathogenic
one more,
mechanism, then is neostigmine
sir,
going to help?
one more action is anticholinergic, sir. Vincristine also blocks the cholinergic receptors.
And generally, it happens on how soon? Is it a dose
Sir,
dependent?
vincristine actually in the available literature, vincristine causing the constipation, and the constipation is very common, sir. So till on the 2nd and 3rd day, it was a natural course for the treating hemato-oncologist. So she was managed under them only. Only when she had increased abdominal distension and the worsening of the symptoms, then only they have referred to us. Occurring of the colonic pseudo-obstruction is in less than 2 to 3% cases, sir.
And in this patient, you had ulcers. So how do you take into that?
It was due to stercoral ulcers because of the constipation.
And I think Shobna ji was trying to ask you, what is the follow-up of this patient? Everything resolved completely?
So like everything by day 7 she was passing flatus,
That's
and she has received vincristine on 8 and 15. The next dose were omitted. She received other chemotherapeutic agents in the protocol.
Thank you so much.
Thank you, sir.
No, I think
ma'am?
time is over. Madam, time is over.
Thank you.
Thank you so much, sir. Now calling upon our third contestant, Dr. Abhinash Mishra, going to present on a topic, a rare case of dysphagia.
All most respected jury members and all the respected faculties, I'll be presenting a case of a dysphagia. It was a story of a 15-year-old male presented with difficulty in swallowing for the last 1.5 years, difficulty in walking and holding objects for the last 6 months. The dysphagia, it was progressive in nature, insidious onset. It was first to the liquid, later it was to the solids. And it was associated with rectal chest pain and regurgitation. Patient is having a history of weight loss of around 6 kg in the last 1 year. In the past illness, the patient's parents, they complained that patient was having a decreased ear from her birth, and there was foreign body sensation and conjunctivitis for the last 5 years. There is a gradual darkening pigmentation in the upper limb and the lower limb for the last 2 years. Patient is complaining of tiredness, dizziness, and frequent falling while walking for the last 2 years. Personal history, the intake has been reduced. In the family history, there is a history of consanguineous marriage in the family. So it is a young male, insidious onset, progressive dysphagia to the liquid with solid, then regurgitation, chest pain, weight loss with recurrent dry eyes and darkened skin. So we may be telling a case of esophageal motility disorder likely of achalasia cardia with skin and eye changes with generalized weakness. On clinical examination, the weight is 46 kg, BMI of 17.53. As per the previous BMI, which was 19, there was dry eye and hyperemic conjunctiva. In the general examination from the head to toe, we can see in the upper limb and the lower limb, there is darkening pigmentation. In the mucosal also, there is darkening pigmentation. So in the abdominal, respiratory and cardiovascular normal. Coming to the nervous system, in the nervous system, there was a bilateral weakness in the ankle dorsiflexion. Ankle jerk and a plantar jerk were diminished. In the baseline investigation, CBC, LFT, RFT was normal, viral marker was negative, and thyroid profile diabetic marker was also normal. So in view of dysphagia to the liquid and solid, we went for the upper GI endoscopy. In the first image, there is a dilated esophagus and residual liquid food material. In the second image, there was a scope, there was a push through while we were passing the endoscopy. So that was suggestive of achalasia cardia. So we went to the next step, that is a barium swallow. In the barium swallow, in this image, you can see there is a smooth narrowing in the distal esophagus with an upstream dilatation, which is suggestive of achalasia cardia. To rule out any pseudo-achalasia in the G junction and maybe cardiac of the stomach, we went for the CCT, that came to be normal. So that raised a more likely of achalasia cardia. Then we went for the high resolution manometry. In the high resolution manometry, the IRP was high and there was pan-esophageal preservation, which is suggestive of type 2 achalasia cardia. By the time we got the diagnosis of achalasia cardia, in view of previous history of darkening pigmentation, tiredness, lethargy, we went for the serum cortisol and that came to be low. ACTH, that was the next step in a follow-up of Addison disease, that came to be high. So when the ACTH is high and cortisol is low, the pathology is at the adrenal. But the adrenal gland came to be normal. So when the adrenal is normal, that symbolizes ACTH is there, but still cortisol is low. That means the ACTH has got a resistance. ACTH resistance is there. The most commonly done test for a dry eye is a skimmer test. In the skimmer test, you can see in the right eye it is 4, left eye it is 6. So skimmer test came to be positive. Nerve conduction study, because previously we were having a CNS manifestation, that was a motor axonal neuropathy. So with this, we got a final diagnosis of achalasia cardia, Addison disease, that is ACTH resistant, alacrimia, peripheral motor neuropathy. That is a classical AAA syndrome. AAA syndrome, it is autosomal recessive disorder because parents are having a consanguineous marriage. Prevalence is 1 in 1 million as compared to achalasia cardia, which is 1 in 1 lakh. Gene is AAA-S, aladin protein, and confirmatory requires a genetic study. These are the clinical features: endocrine, gastrointestinal, dermatological, ophthalmological, neurological. It can also be dysautonomia. Complete triad is seen in 70% cases. Neurological dysfunction, like in our case, CNS manifestation, that is seen in 33% cases. So treatment went for the pneumatic dilation, and this is the image below. That is after the pneumatic dilation, 2 sessions, first in the 3 cm and later 3.5. And patient started with hydrocortisone 10 mg and 5 mg for the ACTH resistant. Carboxymethyl eye drops were prescribed for the dryness of the eye. So clinical suspicion of AAA syndrome should be always kept in mind whenever dealing a case of achalasia cardia with skin or eye changes or neurological manifestation. Thank you so much, sir.
Well presented, sir. It's a rare case, nicely presented. So, any questions from the judges?
Only one more question, please. There is no time.
After starting the steroid, how is the patient with respect to the neurological function?
Ma'am, I'm not getting ma'am sound.
You speak the mic.
What will happen to the neurological symptoms once you start steroids and what are the other options to take care of the other systemic problems which the patient is having?
So neural system asparage in AAA syndrome is actually very rare. This is a case where the neural syndrome. Yes, steroid also can cause neuropathy, so you have to be very cautious while giving the steroid.
Thank
But
you.
neural symptom is normally not seen in AAA syndrome, ma'am.
Thank you. Thank you.
Thank you so much, sir. Now going to call our fourth contestant, Dr. Jay Chudasma, going to present on a topic, achalasia or not achalasia. Is it as simple as we think?
Good evening, everyone. I am Dr. Jay. I will be presenting a case of achalasia or not an achalasia. Is it as simple as we think? So, 70-year-old male presented with a complaint of difficulty in swallowing since 6 months. It was associated with solid and liquid both, with retrosternal pain without any regurgitation or weight loss or any pain, which was non-progressive. It has no other comorbidities and without any similar complaints in the past. So we further went with the upper GI scopy. Esophagus shows normal esophagus without any dilatation, without any food residue, or there was no resistance at gastroesophageal junction. Rest of the examination were normal. At that time, the ECART score was 4. So high resolution manometry was done at the different center on the solid state 36 channel with 10 wet swallows. On median IRP was 16.9 mm of Hg in supine and 17.6 mm of Hg on sitting position. Peristalsis was present, but it was premature with compartmental pressurization in more than 50% swallows. So the impression was kept as esophageal gastric junction outflow obstruction with compartmentalized pressurization. Patient was advised to take PPI and nifedipine and repeat the manometry after 6 months. Simultaneously, patient also underwent HRCT of thorax to look for any outside etiology or any mechanical obstruction. Esophagus showed normal wall thickness and no obvious obstructive mass lesion was present. So patient took PPI and nifedipine for 2 months, but patient's symptoms were persistent. So at this time, patient came to our center, and we further proceeded with high resolution manometry, which was labori, water perfusion 36 channel. 10 wet swallows were done, and this is the chart of the manometry of 10 average wet swallows. And this median IRP of 10 wet swallows were 10 mm of Hg. LES pressure was 14.1. However, 40% swallows showed ineffective peristalsis, but the study impression was given as a normal study. So we further went with the solid swallow. In this, median IRP was 9 mm of Hg. 100% swallows showed ineffective peristalsis, and impression was kept as ineffective motility. So we did the provocative test, which is rapid ring challenge. In that, there is a pan-esophageal pressurization. In supine position, median IRP was 14.9, LES pressure was 42 mm of Hg, and impression was kept as achalasia cardia type 2. Time Miriam esophagogram was also done. It was showing smooth narrowing at distal esophagus and 11 centimeter height of barium column at 2 minutes suggestive outflow obstruction or achalasia. So we kept the diagnosis as achalasia cardia type 2, which is in evolution with ECART score of 4. Patient was managed with 35 mm pneumatic balloon dilatation. After 2 weeks of post dilatation, ECART score was 0 and patient was symptom free. Now patient is symptom free since 6 months. On the follow-up, the high resolution manometry on follow-up, which showed normal IRP on wet swallows and rapid ring challenge, 50% swallows showed ineffective peristalsis. So it was a case of achalasia in evolution. So esophagogastric junction outflow obstruction can be found in normal individuals. Individuals with persistent symptoms should be thoroughly investigated. Provocative test can be useful in the diagnosis of inconclusive manometry findings. Clinical and manometry follow-up is important in inconclusive cases. And supportive tests like time barium and endoflip should be performed in such cases. And pneumatic balloon dilatation should be used to manage the doubtful cases of achalasia. Thank you.
Very nice presentation there. So for the first time around, do you think the rapid drink challenge would, if it would have been done for the first time, the solid state manometry was done somewhere else.
Yes, sir.
So could we have picked up achalasia at that time? Was it achalasia then only, or that was missed out? Since
Sir,
RDC was not done.
sir, first manometry was not done at our center.
No, no,
So,
no.
yes, sir.
Question is that if rapid drink challenge was done at that time, could we have picked achalasia earlier?
Yes, sir. Maybe it could have been picked at that time if a provocative test has been performed at that time.
I think there's a very clear mandate that if in case you have a clinical suspicion and if your manometry is inconclusive, try the provocative testing.
Yes, sir.
So I think that will
Yes,
show.
sir.
That's a very good message that your article has given, is that in this patient, if you had done the provocative test earlier, it is possible that, or you should have done the manometry right then and there. Barium at that time, you would have come to a diagnosis much
Yes,
earlier. Very good case. Thank you.
Thank you, ma'am.
Thank you.
Now, this is going to be a last session of the day. Calling upon the stage our presenter, Dr. Venkatesh V.S., going to present on a topic, Management of Large Mucosal Perforation Following Poem, Masterly Inactivity.
Good evening all. I'll be presenting a case from GPN Hospital regarding management of large mucosal perforation following poem. So our patient is 7-year-old boy who has no history of prior comorbidities, presented with dysphagia for past 6 months, regurgitation for past 6 months. His physical and laboratory findings were unremarkable. Upper GI done, which showed dilated esophagus with liquid food residue and tight lower esophageal sphincter. So high resolution manometry was done, which confirmed the diagnosis of achalasia cardia type 2. So we proceeded with poem, where mucosal insertion was given at 20 centimeter from upper central incisor and submucosal tunneling was done. During submucosal tunneling, we could find a large mucosal perforation was there. However, this is the large mucosal perforation extending from the mucosal incision site up to 6 to 7 centimeter to the distal esophagus. However, we proceeded with submucosal tunneling further to the distal esophagus and 3 centimeter distal to the gastroesophageal junction. So we completed the myotomy esophageal site and the distal to the gastroesophageal junction. Post myotomy, we could find a small rent of size of 0.5 to 1 centimeter just below the gastroesophageal junction with mild ooze was seen, which we could adequately manage with the hemoclip. This injury was adequately managed, following which we started to close this mucosal perforation starting from proximal to the distal end. So proximally one clip was placed and further multiple clips were placed, up to 10 to 12 clips were placed. Even though multiple clips were placed, we couldn't able to close the large mucosal rent of around 4 to 5 centimeter. So we admitted this patient to our intensive care unit. He was kept in nil per oral and he was conservatively managed with IV antibiotics for next 1 week. During this next 1 week, the patient did not develop any history, any fever or no evidence of mediastinitis. We repeated this upper GI endoscopy after 1 week, where there was a large mucosal defect with clips and on the overlying edges with friable mucosal edges. We attempted to close this mucosal edges. Because of the friable mucosal margin, the clips could not be held on. So we did percutaneous gastrostomy was performed and we allowed this mucosal perforation to heal by the secondary intention. He was observed for next 1 week and during that time also he was asymptomatic and he was in a hemodynamically stable condition and he was discharged in post-operative day 15. So we did another endoscopy after 3 to 4 weeks of primary poem day. Percutaneous gastrostomy type was seen and this mucosal injury perforation was healing stage. Superficial longitudinal ulcer was seen with heaped up margin and few clips were seen. During this procedure, During this procedure, PEG tube was removed, oral administration was started, and it was well tolerated without any difficulty. As it was already discussed in this forum, mucosal injuries can be because of thermal injuries or mechanical injuries. In our case, we feel it is mechanical injury because of the shaft injury, which caused the enlargement of mucosal injuries and mucosal incision and mucosal injury. As it was discussed, these type of incision injuries are difficult to manage primarily. Secondary intervention is allowed.
Very interesting. It happens sometimes. Good to show this type of complications. See, I just want to know what you could have done to prevent further progression of the mucosal injury. What do you think? Where did you go wrong?
Sir, injecting good amount of submucosal fluid, sir, that would have been prevented. And we would have selected, since it's a pediatric patient, we could have selected a scope and tunnel size also mismatch was there. This is one of the things.
Many times it is a difficult tunneling when the scope gets bent, and that actually leads the mucosal perforation further.
So for the first time when you realized that there was a perforation which you could not close, then you could have placed a feeding tube right at that time. Why did you leave it to later on? And why do recurrent endoscopies just to see the mucosal healing? Give it adequate time, it will heal.
We plan to close it again, sir. Second endoscopy shoot, we couldn't able to close it, so we put percutaneous gastrostomy.
Yeah, but on day 7, it's very difficult to close a mucosal defect. Tissues don't get opposed.
There was very little chance that you could have closed it.
Thank you so much. It's interesting to show this. Thanks a lot. So we had wonderful cases, 5 interesting presentations. All were very good. Thank you so much.
So thank you all the judges and the participants for some interesting case discussions